Associate Professor of Pediatric Oncology, IAP Thiruvananthapuram, to introduce the speaker. Binitha.
Thank you, Priya. Good evening, respected teachers and dear friends. Dr. Shwetha will be talking to us today about oncological emergencies. In pediatric oncology, we see all the routine medical emergencies that we see in our general pediatric practice. In addition, there are a few specific emergencies that almost exclusively occur only in our pediatric oncology center, pediatric oncology practice. Like Binitha mentioned, we have febrile neutropenia, tumor lysis syndrome, we have the spinal cord compression syndromes and hyperleucocytosis. I think Dr. Shwetha, who is a very good speaker, will be able to enlighten us today on all the aspects of these major oncologic emergencies. Because even though we always feel that it's a pediatric oncologist or an oncology specialized center who will be dealing with these oncologic emergencies, I think that mostly these patients initially present to a general pediatrician who will be doing a general pediatric practice. And so it is very important to understand the various aspects in the approach and the diagnosis and the management of these emergencies. I request Dr. Shwetha to please make her presentation. Thank you.
Thank you, ma'am. Thank you for that kind introduction. I'll just move on to the presentation. I'll just share my screen. Yes, so today we are going to discuss oncologic emergencies. What is the role of the pediatrician? Like sir and ma'am had mentioned, pediatric oncology is mainly a referral specialty. So most of the patients will first present to our pediatric colleagues before they come to us. And although pediatric cancer is rare, sometimes these cases may present in a state of oncologic emergency. So the aim of this presentation is just to give you some extra information regarding how to manage these patients if they come in a state of oncologic emergency to you. So I'd like to start with this slide. It shows the cancer incidence rates for patients aged 0 to 14 years. And as we can see, the largest chunk, that is 31% of it, is due to leukemia. So acute leukemia is the most common type of pediatric cancer that we see. It's followed by CNS tumors, which account for nearly 26% of all tumors, followed by lymphomas, which are around 10%. And this whole area is dedicated to all the solid tumors that we come across. For example, the soft tissue sarcomas, we have neuroblastoma, then we have the renal tumors like Wilms tumor, and bone tumors like osteosarcoma and Ewing sarcoma. Then this is a slide that I like to show in most of my presentations. It's a very beautiful pictorial representation of the childhood cancer warning signs. This poster was brought about as the Signs and Symptoms campaign by IAP, which is the Society of Pediatric Oncology. It's a European society. And they brought it about to improve the childhood cancer awareness. And it's a very nice poster which helps us to remember the warning signs. So the first picture shows a child with pallor, bruising, bleeding, and general bone pain, which is a common sign of acute leukemias. Then the second one, we can see lumps or swellings, especially if they're painless and without any fever or other signs of infection. Unexplained weight loss or fever, sweating at night. These are all B symptoms that are commonly associated with lymphomas like Hodgkin's lymphoma. Then eye changes that we see, that we can see in white pupil or a new onset squint, which is commonly seen in tumors involving the eye like retinoblastoma. Patient can present with a new squint and visual loss if the patient has brain tumors, or you can have bruising or swelling around the eyes, which is commonly seen in metastasis from neuroblastoma. Then patient can have abdominal swelling, that is mostly the abdominal tumors like Wilms tumor or neuroblastoma or some of the soft tissue sarcomas. A patient who presents with severe persistent headache associated with vomiting, mostly early in the morning, is probably a very strong sign of brain tumors. You may also have limb or bone pains without a history of trauma or any sort of infection, which is a sign of the bone tumors that we have. So coming to the talk proper, we'll be discussing case scenarios. So the first case is a 12-year-old boy with intermittent fever, bone pains, and generalized abdominal pain since 1 week. He complains of intermittent mild abdominal pain and vomiting since 1 day, and he hasn't passed urine in the past 12 hours. So on examination, we see a sick-looking child with scattered petechiae, a heart rate of 110, he's normotensive, and he is afebrile. So when we send the baseline investigations, we see hemoglobin of 7, total count of 80,000, platelet of 90,000, differential count is showing abnormal cells, and the renal panel shows urea of 63, creat of 1.8, LDH is 2,565, and the LFT is normal. So now we have a child with abnormal counts. Most probably he has leukemia, and that is associated with an abnormal renal function, history of decreased urine output. So how to improve the urine output in this child? Do we give hydration? Do we give LAS6? Do we give both? And any further investigations needed? So now when we have a suspected leukemia case with a high count and an abnormal RFT, we should further investigate the child by sending a uric acid as well as the serum electrolytes. So the uric acid level is 8.5, potassium is 4.7, calcium is 7, and phosphorus is 6.8. So we see that he has got hyperuricemia, he has hyperphosphatemia, and he has hypocalcemia. So now what is the impression? In a child with suspected leukemia and this sort of biochemical profile, we are suspecting the patient has got tumor lysis syndrome. And so one clinical question is, he's got hypocalcemia. So how are we supposed to correct this calcium? Before we go into the calcium correction, I'd like to show you a slide regarding the Cairo-Bishop definition for laboratory tumor lysis syndrome. Mainly 4 parameters are looked at here: the uric acid, potassium, phosphorus, and calcium. So if the uric acid level is more than 8, or the potassium level is more than 6, phosphorus more than 6.5, and a calcium of less than 7 in the baseline, or as we can see in the latter end of the slide, a 25% from the baseline. So if we've taken a baseline value and the follow-up value is showing a 25% increase, or in case of calcium, a 25% decrease in the baseline, that is also taken as significant when we are discussing this particular definition of tumor lysis. So laboratory tumor lysis is defined as either a 25% change or level above or below normal for any 2 or more of these serum values. So any 2 or more of these biochemical values, if they are abnormal, within 3 days before or 7 days after the initiation of chemotherapy, that is taken as lab TLS. Cairo-Bishop also gives the definition of clinical TLS. So that is lab TLS along with a serum creatinine of more than 1.5, presence of any cardiac arrhythmias or sudden death, and presence of any seizures. So now this patient, we know he is in TLS. So how do you manage this child? He requires hydration of 1/4 DNS given at 3 liter per meter square. So this we call it hyperhydration because 3 liter per meter square is a very high rate. And so how do you make 1/4 DNS? So what you do is you take D5, take 1/4 of that, which is 125 ml of D5, and replace that with DNS. So that gives you the hypotonic fluid, 1/4 DNS, which is what we use for hyperhydration. And urine output needs to be strictly monitored. We are aiming at a urine output of greater than 80 milliliters per meter square per hour. Because this child has got hyperuricemia, we will give him allopurinol 10 mg per kg per day in a divided dose. And sevelamer. Sevelamer is a phosphate binder. Because he has hyperphosphatemia, we will start it at 400 mg TDS if the body surface area is less than 0.75, 800 mg TDS if a body surface area is more than 0.75. This dose may be increased up to 1600 per dose. Usually it's increased in increments of 400 mg. So calcium correction. No, we do not go for calcium correction. A patient with high counts who is in TLS is at risk of having increase in the phosphate levels within the blood. With a person who has a high phosphate level, as we correct the calcium, this will push the calcium phosphate ratio towards deposition of calcium phosphate crystals. And when these crystals deposit within the renal tubules, it will worsen the renal dysfunction even further. So we don't go for calcium correction in a patient with TLS unless they are developing signs of hypocalcemia like tetany. So only then do we go for calcium correction, and then again a very measured, very slow correction is given. ECG monitoring is definitely recommended. because these patients are at also high risk of developing hyperkalemia and its problems. Potassium-free fluids and low potassium diet should be advised. Generally in our region, if a patient develops any sort of complaints, he is offered coconut water. Coconut water, bananas, they're all high in potassium, and we do not give them to a patient who is at risk of hyperkalemia due to TLS. Then judicious use of Lasix. So now in this particular patient, there is a fall in the urine output. So if the hydration does not improve the urine output, another option is to give Lasix. I do advise judicious use of Lasix because of the high counts in this patient. We do not want him to go into any form of dehydration at all. So Lasix has to be very carefully given. We will discuss this judicious use of Lasix even further in the next case. If the urine output drops despite these measures of hydration and Lasix, the patient may need to be taken up for dialysis. So going on to case 2, we have a 10-year-old patient who presents with intermittent fever, fatigue, mild headache since 2 weeks. On examination, I'll continue. So on examination, he has pallor, scattered petechiae, and hepatosplenomegaly. So fever, fatigue, pallor, petechiae, and hepatosplenomegaly is definitely indicative of leukemia. Baseline counts shows a hemoglobin of 6, total count of 1.5 lakhs, and a platelet count of 15,000. So this patient has anemia. How much packed RBC transfusion should we give? How many units of platelets should we give? And what further investigation should be sent? So after the discussion of case 1, we know that patients who are having high counts are at risk of tumor lysis syndrome. So all the biochemical investigations that we have sent for case 1 will be sent for case 2 as well. And we will discuss further regarding the transfusion requirement. So now this patient has got hyperleucocytosis. The total leukocyte count is more than 1 lakh. These patients are at increased risk of thrombosis. Now, the reason for this is because traditionally it was believed that a patient who has hyperleucocytosis, they have increased viscosity of the blood. And because of that, they have an increased risk of undergoing thrombosis. Now studies are also showing that the blast cells, that is the lymphoblast or the myeloblast, they also have increased interaction with the endothelium of within the vessel, because of which they have the tendency to form clusters and they adhere to the endothelium, again increasing the risk of thrombosis. These patients are at increased risk of hemorrhage as well. And depending on where the thrombosis or the hemorrhage occurs, they may develop neurological or pulmonary complications. Neurological complications like seizures, coma, stroke-like symptoms, pulmonary complications like sudden onset dyspnea. So how to manage these patients? Definitely hydration has to be given as they are at high risk for TLS, and judicious transfusion. By judicious transfusion, platelets should definitely be transfused. This patient's platelet count is 15,000. In a patient with hyperleucocytosis, it is advised that if the platelet count is less than 20,000, we should transfuse them because they are at high risk for hemorrhage. However, packed RBC transfusion should not be given in a patient with hyperleucocytosis. Packed RBC itself is a very viscous blood product, and transfusing this to a patient who has hyperleucocytosis will increase the blood viscosity even further, precipitating thrombosis. Now, since this patient, although he has a hemoglobin of 6, he is not in any form of cardiac failure, this patient we will not transfuse with packed RBC. Then we also need to watch for the signs and symptoms of these sudden events, the sudden neurological event or pulmonary event. Early referral is paramount. It would also be advisable to talk to the parents, to counsel them regarding the presence of hyperleucocytosis and the possibility of a sudden event happening even while transferring the patient. And tumor lysis syndrome, definitely. So we need to take all the precautions for tumor lysis, giving allopurinol to this patient, whether sevelamer needs to be given or not, monitoring the urine output, giving hydration. All of that is very important even when transferring the patient. So going on to case 3. This is a 13-year-old boy who has presented with complaints of cough, breathlessness, and occasional facial edema. On examination, he has cervical lymphadenopathy, significant cervical nodes, and the hemoglobin is 7.5, platelet is 32,000, total count is 65,000. So he has abnormal counts. And the chest X-ray shows this. So this patient has a mediastinal mass. Now, how to go about evaluating this child further? Do we go for a mediastinal biopsy? Do we go for a bone marrow? What do we do for this patient further? So first of all, this patient is showing features of SVC obstruction. SVC obstruction is because the mediastinal mass causes a mass effect on compression of the superior vena cava. This presents as facial flushing, conjunctival congestion may occur. There may be, the neck veins may be full, and some amount of facial edema may also be present. When these features of SVC obstruction is associated with breathing difficulties or wheezing, which is indicative of some sort of tracheal compression, then that is known as superior mediastinal syndrome. So further evaluation in this patient, CT chest is warranted to assess the airway. Now, when we think of taking a CT chest, traditionally, of course, we place the patient supine. In this case, because of the presence of the mediastinal mass and the patient is already complaining of some amount of breathlessness, if we place the patient supine, that mediastinal mass will further compress on the trachea and breathing difficulty will even worsen. So we can go for a prone positioning when we're doing the CT chest. And this is what the CT chest shows. As we can see here, there is some amount of tracheal compression due to this mediastinal mass here. So the dictum for evaluating a mediastinal mass is least invasive procedure first. So we will go for a peripheral smear, we will go for a bone marrow aspiration. If there is pleural fluid, we have been able to diagnose a patient by tapping the pleural fluid and sending it for flow cytometry. So even pleural fluid aspiration is good. If we have to go for a node biopsy and there are peripheral nodes available, definitely go for the peripheral node. The most invasive of the list of procedures would probably be the mediastinal biopsy. So that will come last in a case of mediastinal mass. And one major thing that we have to know is that you have to avoid sedation in these patients. The reason for that is in a patient with mediastinal mass, the only thing that may be keeping the trachea patent is the normal tracheal tone. If you give deep sedation to a patient who has a mediastinal mass, there will be a loss of that tracheal tone, leading to a sudden compression of the trachea, and the patient can go into sudden dyspnea. Also, any form of general anesthesia, it causes a decrease of the lung volumes occurring. Also because there is an increase in the pressure, in the intra-abdominal pressure, a decrease in the lung pressures, causing the diaphragm to be pulled upwards. Because of that, the lung volume will decrease further and it will compromise, there will be respiratory compromise in the patient. So when it comes to positioning this patient, we try and position the patient in the upright position. When we are transferring also, you prefer to keep the patient in the head up position, and he may be positioned either left lateral or right lateral or even prone. The reason for going for these positions is to decrease the mediastinal mass effect on the trachea. Now, what is the role of steroids? Actually, giving steroids to a patient who has a mediastinal mass, especially in this case, like we have abnormal counts associated with the mediastinal mass, so it's most probably acute leukemia, lymphoblastic leukemia associated with a mediastinal mass. Lymphoblasts are exquisitely sensitive to steroids. So once we give steroids, it takes less than 48 hours for the diagnostic picture to change completely. So once we give steroids to a patient and we transfer them, by the time they reach the cancer center, we may have difficulties in diagnosis. But there are instances where a patient will present to you in an extreme state of emergency. You may feel that this patient is not going to make it, that respiratory arrest is imminent, and of course, life before diagnosis anyway. So in those cases, there is a role of steroids in these patients. Especially IV steroids, IV dexamethasone is very effective in acting on these mediastinal masses and causing a decrease in the tracheal compression. So if at some point steroids is given to this patient and we have a diagnostic dilemma, What we usually do is that we will keep the patient on a close follow-up until they again start showing signs of leukemia or mediastinal mass occurring, and then we will go on to the further diagnostic workup. One thing I'd like to stress here, I've kept it in caps, is there is no role for surgery. Very, very rarely have we had a mediastinal lymphoma presenting post-surgery to us. There is no role for surgery except in the case of taking a diagnostic biopsy. So just a huge thoracotomy scar will be left for that patient, and it is really not required. Now coming to case 4. Case 4 wouldn't be the traditional oncologic emergency. It doesn't really come under the purview of maybe an oncologic emergency. But I really would like to discuss this case over here because it's a very, very important aspect of our cancer care, and we really need the help of all our colleagues when it comes to taking care of these cases. So here we have an 8-year-old child who is a known case of acute lymphoblastic leukemia. Child is on maintenance chemotherapy with tab 6MP and tab methotrexate. Now this patient comes with complaints of fever and cough since 1 day. On examination, the patient has a temperature of 101 degrees Fahrenheit. The heart rate is 110 per minute. The patient is normotensive and saturation is 98%. On auscultation, we get scattered Krebs and the other systems are within normal limits. So how to investigate? Any patient who is on chemotherapy and presents to you with fever, do send a complete blood count in that child. Even if the counts have been done 2 days before. Because of the immunocompromised state of these patients, it doesn't take long for a small infection to become a big infection in them. And it doesn't take long for the counts to fall also suddenly. So even if the counts have been done 2 days prior, do go ahead and repeat the CBC. And I've added CRP over here. Although CRP is not a very sensitive test, it may give us an indication regarding underlying infection. Again, because these patients are immunocompromised, they may not have the typical signs and symptoms of infection that a normal child would show. Sometimes the signs and symptoms will be very subtle. So sending a CRP may give us an idea regarding some underlying infection that we may miss otherwise. So the total count in this patient is 900, an ANC of 300, and the CRP is 25. So there is definitely some infection here, and the patient is in neutropenia. So this patient has febrile neutropenia, a single oral temperature of more than or equal to 101, or a temperature of greater than 100.4 for at least an hour, with an absolute neutrophil count of less than 1,500 cells per microliter. This is the definition of febrile neutropenia. So this is just for your information. Generally, when we treat a patient with febrile neutropenia, we risk stratify them into high risk and low risk. So the high risk patients are those who have profound neutropenia. That is an ANC of less than 100. And this ANC of less than 100, we anticipate it to extend for more than 7 days. And if they have any comorbid medical problems like hemodynamic instability or severe mucositis or any abdominal pain, nausea, vomiting, diarrhea, presence of any new neurological symptoms, then the presence of an intravascular catheter, any central lines present, if they show a new pulmonary infiltrate, or there is any evidence of hepatic insufficiency or renal insufficiency, all of this is grouped under high risk. And a low risk patient are those in whom we expect the neutropenia to resolve within 7 days and they have no active medical comorbidity and they have stable and adequate hepatic and renal function. So that is high risk and low risk. So coming back to this child, this imaging is warranted in this child. All the guidelines for febrile neutropenia, they advise doing a chest x-ray in those patients who show respiratory symptoms or signs. Routine chest x-ray in patients with febrile neutropenia is not advised. And definitely send a blood culture for all febrile neutropenia patients, send a blood culture and start them on empiric antibiotics. Now the FNP guidelines, febrile neutropenia guidelines, they advise mono antibiotics are, monotherapy is advised now. The antibiotics of choice that they have come across now are cefepime, piperacillin, tazobactam, and the carbapenems because of their broad spectrum. So broad spectrum antibiotics are advised. Earlier, we were following more of combination antibiotic therapy. Now they are favoring more of mono antibiotic therapy. Again, combination therapies may be given. We may add an extra antibiotic based on the prevalent pathogens that we see. High rates of GNBs within the setup that you work in is an along with hemodynamic instability in the child, is an indicator for adding a second antibiotic for gram-negative coverage. In case of a child who has who's come in shock, who has some sort of soft tissue infection or some catheter tunnel infection, again, adding vancomycin is warranted. So based on the symptoms of the child, we may add further antibiotics on. So baseline though, cefepime, piperacillin, tazobactam, and carbapenem may be given. This is because any patient who comes to you with febrile neutropenia, please know that the clock is ticking. In the West, they have done numerous studies on sepsis and septic shock, and they have come up with that golden hour theory, where they advise a door to needle time. That is the time the patient comes through the door to the time that the patient receives the first dose of antibiotic to be within 1 hour. In febrile neutropenia also, there are many centers that are trying to bring about this golden hour for administering antibiotic to a patient with febrile neutropenia. It is extremely difficult. They have done studies in various centers to assess how many patients are actually getting antibiotics, even within the cancer centers, how many patients are actually getting antibiotics within the hour. And I think they were able to only give 25 to 30% of cases these antibiotics within the hour. But it really makes a difference, because if we follow the golden hour, because giving early antibiotics, it decreases the complications that the patient develops. It decreases the need for further intensive care in these patients. Previously, when I gave this talk, one of the doctors had asked me, so it takes more than 1 hour for us to even get the counts in the patient. So how are we going to follow this golden hour? Definitely, that is definitely a thing to think about. But there have been many instances where even after we have diagnosed that the patient has neutropenia and we've received the counts of the patient, still we have not been able to give the antibiotics in a timely manner. There have been instances where antibiotics were delayed from up to 3 hours, either because antibiotics were not available, or they had to go somewhere, or cannula was not there, or something or the other has happened, and the antibiotics were delayed. But definitely early antibiotics is of the utmost importance. So please know that the clock is ticking. And GCSF also is a good option in this patient, because the ANC is only 300. So GCSF is given at a rate of 5 mg per kg per dose subcutaneous OD. Coming back to the risk stratification that we saw earlier, high-risk patients, ideally, of course, they have to be admitted. Low-risk patients, the risk stratification is done in low-risk patients so that we have the option of giving them oral antibiotics and keeping them on a close follow-up. Of course, this is only opted when we know that we can ensure that follow-up, it's going to be strictly done, and the patient is well enough. So oral antibiotics can also be given. Oral antibiotics such as amoxicillin or ciprofloxacin may be given. In this particular patient though, because the child is having a neutrophil count of 300, is having CREPS, I would ideally advise admitting the child and giving antibiotics at least for 48 hours under admission. And if he improves, the count improves, etc., we can think of an early discharge and then a close follow-up on oral antibiotics. So just the highlights, some points that I wanted to stress from this talk is hyperhydration, strict intake output has to be followed in a patient who has high counts with suspected leukemia. Avoid packed RBC transfusion in a patient with hyperleucocytosis. Avoid sedation in a child with a mediastinal mass, and administer the first dose of antibiotic as soon as possible in febrile neutropenia, preferably within the hour. Okay, thank you for your patient listening.
Thank you, Shwetha, for the presentation. I think there are a few questions in the chat box, which you might attempt. Actually, Jayama sir, I didn't get the first question. I'm so sorry. What is the, sir?
No, I asked whether what is the best for hyperuricemia?
Hyperuricemia.
What is the best? What is the best drug? Hyperuricemia.
For
best drug for hyperuricemia.
Yeah.
The best drug for hyperuricemia is probably raspuricase, urate oxidase, because it is quite expensive. We don't routinely give raspuricase for all our patients. We usually start with hydration and allopurinol, but definitely the best drug is raspuricase.
Okay, thank you.
Thank you, sir.
So the second question is from Shija ma'am. Why is 1/4 DNS recommended for TLS as it is hypotonic? Won't it go to extravascular space more? The British committee recommends isotonic or balanced fluid for TLS treatment. Any newer recommendations?
These are, ma'am, this is actually the newer recommendations according to me. Binitha ma'am can definitely back me up over here if you have anything further.
Shija ma'am, actually, when the problem that I think I'm not very sure whether I'm technically correct, because if we are giving normal saline isotonic fluid, the total amount of sodium load to the child will be very high.
Yeah,
because we are giving double the normal
a very high
maintenance.
amount.
So if the normal maintenance is at 1.5 liter per meter squared per hour, you're giving 3 liter per meter squared per hour. So if you're giving an isotonic fluid, say normal saline, the sodium load is going to be very high. That's just why we have traditionally been giving the less, the more hypotonic fluid like 1/4 DNS.
Usually when we have patients with myoglobinuria, we go for isotonic fluid itself. Now you have normal saline as well as you also have plasma light, which is a more balanced solution, which will again have sodium slightly lesser at 145. But we haven't come across hypernatremia if we are not dealing with an infant. If an infant or a young child, definitely, as you said, 1.5 times with an NS would definitely higher risk of going for a sodium overload. But bigger children, definitely 1.5 times hydration, because that is many situations you use 1.5 time hydration. Many poisonings you use 1.5 time hydration. There we usually don't come across. Dr. Shwetha, could you tell me which is the guideline that you follow now? Because I had referred this and this is the 2015 guideline that I have quoted. Can we have, which is the one that you have quoted? We could just go back to
the same only, madam. It's the 2015 guidelines.
Yes, ma'am.
I know. Which society did we look for that? Which
British committee, or British standards only, madam. The 2015 guidelines. That is what I know that they recommend that isotonic fluid only there, but it is more of a traditional way we have been always following it. We'll maybe check. We'll just go back and check,
ma'am. I am actually quoting from the review article by Dr. Pui from St. Jude. They've written an article in NEGM on tumor lysis syndrome, and there also they have quoted. These are the guidelines that they have quoted.
1/4 DNS.
1/4 DNS, yes. I think they have quoted it as the 5% dextrose with 0.22%, which is
only. That won't be even 1/4. That will be 1/5.
That is slightly less than
slightly without potassium.
Yes, without potassium, definitely without potassium. Earlier also, ma'am, they used to recommend. There are still some places where they recommend alkalinization, some places where they do not. Currently, we do not follow alkalinization because although alkalinization helps in excretion of the uric acid, it pushes the calcium phosphate towards deposition. So we don't follow alkalinization also, we give plain.
And I think alkalinization, we don't have a doubt. All the guidelines say no more alkalinization. I was only bothered about this isotonic and hypotonic because there's too much of this thing into using hypertonic fluid. Anyway, good to know. Please. Thank you.
Thank you, ma'am.
The question is from Anbu. How to decide on febrile neutropenic cases if the count is expected to rise in less than 7 days or more?
So if the counts are expected to rise less than 7 days or more, that usually comes under the purview of low risk febrile neutropenia if the child does not have any other comorbidities. So in a low risk febrile neutropenia, actually we have the option of keeping the child on an OP basis and starting them on oral antibiotics, again based on the clinical picture. But this should only be attempted if we are able to keep the child on a close follow-up and we can ensure that follow-up. Otherwise, it will always be safer to admit the child. And usually these, our maintenance chemotherapy children, they have not received any intensive chemo in the recent times. So most of them, we do expect the counts to rise within the 1 week. most of those patients will fall under low risk.
And Viraj, basically, we basically decide depending on the other existing, if there is a focus of infection, is there any hemodynamic instability, all these factors, how low is the count, is it a very profound neutropenia, is it, if the ANC is less than 500, multiple factors are taken into account. So is there any other organ dysfunction that has set in? So all these factors are taken into consideration. It is not only the expected duration of neutropenia that we take into consideration. And as Shwetha stressed, if it is okay, if we can ensure that the patient will come to you for regular follow-up, if the patient is otherwise hemodynamically stable, oral antibiotics might be sufficient. But what we generally feel is in the periphery, it would be better to start on IV antibiotics, to take in the patient, to keep the patient as an inpatient and start on IV antibiotics if the absolute neutrophil count is actually very low. That would be irrespective of the rise in count. And when we are expecting the count to rise, practically that would be the best situation. That's what we have always felt. Shwetha, next question is from Jayumar. Sir, will you withhold calcium even if the child is having tetany?
No, if the child is having symptoms of hypocalcemia, we will definitely go ahead and give calcium very carefully. The reason we try and avoid calcium, as I mentioned earlier, sir, is because these patients are at risk of hyperphosphatemia also. As we increase the calcium levels, the calcium phosphate ratio changes, and because of that, it can deposit as calcium phosphate crystals within the kidney. And actually now, because of the presence of rasburicase and allopurinol, we don't see as much kidney damage happening due to uric acid as much as because of calcium phosphate. We are having a lot more trouble because of the phosphate deposition within the kidney, which is why we try and avoid calcium as much as possible. But definitely if the patient is showing signs of tetany, we will go ahead and give a slow correction.
That's all the questions we have in the chat box. Priya, shall you wind up the session, or are there any more questions from the crowd?
Are there any more questions? Any questions? If there are no questions, then we'll move on to the monthly newsletter release. Bennett, sir,